I think we can start. So thank you all for joining us this evening. Can I just please ask you to mute your microphones, just so we don't have any echo in case somebody hasn't been muted yet. So my name is Lucia, and I'm an MD by training. I currently work as a glycanage advisor, and I also do some glycobiology research at the Ganas Lab. This is our first webinar in 2023, and we'll be talking about the boom of the supplement market. So I hope that you will find some of this information useful. So I'll introduce the revised hallmarks of aging, because that will be something that will be quite relevant this evening. I'll talk a bit about the trends of dietary supplement use, different definitions and nomenclature, and then the most important bit, the evidence behind some of the most commonly used supplements, as seen having worked with different clients so far, and what we can do with supplements, how we should be using them, whether to promote health and longevity in the future. That will be the last thing we will discuss today. I think it would be good if you have any questions, just to make a note of them, so we can go through all the questions at the end of this webinar. So as I said, it's good to go over the revised hallmarks of aging, just for introduction. So as you might know, in 2013, Lopez-Otin and colleagues brought 9 hallmarks of aging. And that changed last year when 5 new hallmarks were added, and amongst them was inflammation as well, which is, as you know, something we're keen to explore in terms of IgG glycans and our glycanage test. The meeting that took place in Copenhagen last year basically concluded with saying that, you know, it is important to look at each of these hallmarks individually, but what's even more important is the interconnectedness of them all. And that is something that we see supplements might help us with, not only touching upon one individual hallmark, but many different ones. And the examples I'll be giving you today will prove that as well. So just to start with, as you are all aware of, everybody uses supplements these days. Well, I can't personally think of anybody around me who does not. So we've seen 4-fold increase in the use of vitamin D and 7-fold in the use of omega-3. And that was just from 1999 to 2012 in the US alone. That trend is ongoing. And I think it particularly was evident during the COVID-19 pandemic, when everybody was buying loads of vitamin D and zinc, for example. We see that supplement use is positively related to education and to socioeconomic status. So your typical client who will be taking many supplements will be a well-educated person, quite wealthy, a non-smoker, non-obese individual. And we also do see that women are more keen to take supplements than men. So I think we can say that from, you know, if we compare what was going on in the 18th century and when individuals there back then were treating clinical deficiencies, now today we focus on the treatment of subclinical nutritional deficiencies, but also trying to use supplements as a way to promote and optimize health and longevity. This is just to show you, and this is the data from the US National Center for Health Statistics, which is available on their web page if you want to have a detailed look. But you can see that if you look at the population in the US who are 20 or over, more than 1 in 2 people will be using at least supplements a day. You can see there is some difference when women are compared to men. And in this graph here, you see how with increasing age, the number of supplements also increases steadily. So by the time we are 60 or over, it is estimated that 1 in 4 of us will actually be using at least 4 supplements a day. On the other hand, it is somehow paradoxical that at this point in time, even though many people do supplement with different vitamins and minerals, we do see still that there is an inadequate intake of some of these, especially vitamin D, as well as vitamin E and magnesium. And at the same time, there is an excess intake of some of these vitamins and minerals, for example, niacin and zinc being 2 most prevalent ones. In terms of the definition of a dietary supplement, so if you look at the US, Food and Drug Administration basically defines supplements as foods, as long as they contain at least one of the dietary ingredients, which basically can be any of these. So a vitamin, a mineral, a herb, or an amino acid, as well as this, which I think of can be anything really, a dietary substance to supplement the diet by increasing the total dietary intake, or a concentrate, metabolite, or a combination of any of the previously mentioned ingredients. In the EU, things are slightly different, and I think the UK still has a similar framework in place. So the EU defines a definitive list of minerals and vitamins, and then everything else from this list is up to each individual EU country to decide about. In both of these instances, which is very much seen in the US, FDA doesn't really need to approve supplements before they enter the market, which is, I think, slowly getting out of hand with many different companies producing many different supplements. The global market of supplements will continue to increase and has been steadily increasing in the past 2 decades, as I said. And I think the fact that manufacturers are not required to prove whether these supplements are effective or safe is one big issue. Obviously, you also have to bear in mind that supplements are not held to the same quality standards as pharmaceuticals, which basically means that it is very difficult for an individual to judge which supplement is of poor and which supplement is of good quality. And we also have an issue with a dysregulating marketing. And just to give you an example of another issue, so this sentence here is also part of a supplement definition by the FDA. And it basically says that something that has already been defined as a medication or something that is being looked into, potentially being a new medication, cannot be treated under the supplement category. And this is something that was relevant in the past few months. Probably you've heard of what happened with NMN. So NMN is a supplement that has been, well, it had been a supplement so far, but one of the companies basically let the FDA know that they're looking into potentially using it as a medicine, and FDA had to, file a letter to all the manufacturers to say that, well, now you can't really sell this supplement as a supplement anymore. What's going to happen with that? It's not really clear at this point in time, but this is something that NAC supplement had been through in 2021. NAC, as you probably know, is used and has been used in medicine since the 1960s, first as a tool in management of paracetamol overdose, and also as an inhaled product in certain respiratory diseases. So what happened is that out of blue in 2021, FDA decided to say, well, NAC can no longer be a supplement because it had been defined as a medication before. And basically that is what they wrote in a letter that was addressed to the manufacturers, after which many people complained. And then FDA decided to basically to exercise the enforcement discretion policy that applied to NAC, which basically meant that even now today you can still buy NAC supplements. So there's many different regulatory issues here, and some things are well defined, some are not. Now onto the evidence behind the use of some of the vitamins and minerals. So for any medication or for any supplement, we should really be thinking about evidence that's been proven and showed in human beings, obviously starting first with animal studies, which if they have any positive results can be tried and replicated in humans. As with supplements, as also with what are now called gerotherapeutics, we want to see what effect supplements might have firstly on animal lifespan and health span, whether that's done in mice or in worms or similar, and whether they can help attenuate hallmarks of aging. And then the idea is to try and replicate the findings or find something else in human beings. So whether that is affecting the health span, which basically means ability to prevent or reduce the progression of age-related disease, or whether that has any effect on mortality. So to start with, multivitamins are probably one of the top 3 supplements taken by many glycan age clients, and I guess taken by many individuals worldwide. If you look at the evidence behind their use in terms of trying to prevent some of the non-communicable disease, you will find no evidence as such. Actually, this big study by Jenkins and colleagues that was published in the Journal of American College of Cardiology found that actually multivitamin use had no significant effect on cardiovascular outcomes, on cardiovascular deaths, and on all-cause mortality. And actually, on the contrast, that some of these combination of different multivitamins or antioxidants might even cause an increased all-cause mortality. Similarly, in case of type 2 diabetes, there was no evidence that any of these individual vitamins, nor in any form of combination, helped prevent type 2 diabetes. When it comes to B vitamins, there is some evidence that actually from the same study that folic acid and B complex had a positive impact on stroke risk reduction, as well as cardiovascular disease reduction in case of folic acid. And that actually niacin supplements, which is vitamin B3, which, and if you remember, I mentioned this, this vitamin sometimes in some cases being orally used in a way. This one was associated with an increased all-cause mortality. Some of the other research groups also wanted to see whether, and for the right reasons, obviously, whether folic acid supplementation had any effect on cancer risk, and they couldn't find any relationship there. So it neither increased or decreased site-specific cancer risk. Omega-3 fatty acids, again, I would say in my experience so far, a top 5 supplement amongst my clients. One important randomized control study, which you might have heard of, was called Vital RCT, which looked at the use of omega-3 and vitamin D. Essentially, in case of omega-3, daily supplementation at the dose of 1 gram did not reduce the risk of cardiovascular events. Following this RCT, there was one big meta-analysis that took the results of this RCT and 12 other ones and found that actually omega-3 supplementation seemed to significantly lower the risk of many of the cardiovascular endpoints. And that decrease in risk was very much related to dose. There was quite a positive relationship, linear relationship really between the dose and the risk reduction. In terms of cancer, the same Vital RCT showed that omega-3 fatty acid supplementation was not linked to any cancer risk reduction. And again, sadly, in terms of type 2 diabetes, from a different meta-analysis and systematic review, there was no evidence to promote the use of this supplement in order to prevent or treat type 2 diabetes. Just to give you an overview of one of our papers, which was published in Glycobiology in 2021. So it was a small RCT that essentially had a look whether omega-enriched hen eggs had any impact on IgG, as well as total plasma protein glycans. What the team did was they compared this amongst individuals who were healthy and also amongst those who had some form of cardiovascular disease. And so the idea was that for all of the individuals who took part of this RCT, everybody would be having 3 hen eggs a day for 3 weeks. It was just that the intervention group was having omega-3 enriched hen eggs instead of just normal eggs. And the results are really interesting. So in a healthy group, you can see that those individuals who were having omega-3 enriched hen eggs had quite a significant, and this was a statistically significant change in terms of the amount of bisecting glycans. And if you remember, bisecting glycans are pro-inflammatory. So the reduction was then an anti-inflammatory change. In the cardiovascular group, there was no change in terms of IgG glycan profile, but this group did show quite an extensive change in the rest of plasma protein glycan profile. You can see a complex series of changes, which can actually be explained as anti-inflammatory. So essentially, we did see that in terms of IgG glycans, in terms of what we would call glycan age, we did see that healthy people who were eating omega-3 enriched eggs showed some anti-inflammatory change in their IgG glycan profile after 3 weeks, but those who had some cardiovascular problems before this study was done had shown quite an extensive anti-inflammatory changes in their other plasma protein glycans. Vitamin D, I mentioned, so with omega-3, this was something that was looked at in the VITAL RCT. So in terms of cardiovascular disease, that randomized controls trial didn't show that daily supplementation of 2,000 units a day had any effect on cardiovascular events, nor on cardiovascular mortality. And another RCT, which looked at vitamin D supplementation, but at high doses once a month, also didn't see that that was related to any cardiovascular disease prevention. What was interesting and what is interesting about vitamin D is that in the latest meta-analysis, it looked as though vitamin D supplementation was related to a significant reduction in cancer mortality, but not in cancer incidence. And again, for type 2 diabetes, vitamin D supplementation hasn't so far been related to any risk reduction. And the last of these vitamins and minerals is zinc, which you probably heard of being used as a way to prevent and shorten any acute respiratory illness. Zinc has also been looked at in terms of trying to shorten or actually reduce the progress of prediabetes to diabetes. And RCTs have been done both in the developing countries, so one in Sri Lanka and one in India, as well as in the high income countries such as Australia. And here is a difference. So RCTs that were done in Sri Lanka and India, which basically had supplemented zinc at a much lower dose than what they did in Australia, showed that actually this had a positive effect on glucose parameters. Whether the Australian study showed that a supplementation of 30 milligrams a day, which is quite a dose, did not make any difference, nor reduce the chance of progression to diabetes. So this kind of, you can ask yourself a question of why that is, and this is something which is a common issue in RCTs. In the design of these trials is that nutrient level is not normally taken into account, not normally, but frequently is not. So if you imagine in a low or middle income country, you're way more likely to see individuals with certain vitamins and mineral deficiencies. So it is, you would expect that if you supplement zinc in people who were actually deficient, that you might, see some positive effects of such supplementation. Whereas in Australia, where my best educated guess would be that zinc deficiency is not as common in somebody who doesn't have any dietary restrictions, that would definitely not have the same effect. Zinc supplementation was also looked into in terms of trying to prevent age-related macular degeneration, which is basically the main cause of legal blindness in the developed world. And the number one risk factor for that is aging. But so far the evidence is inconclusive. And the last mention here is just some animal research done by different research groups and not us, that basically looked at the effect of zinc supplementation on recombinant IgG glycans. So essentially, what this research group did is that they supplemented zinc to ovarian cells of hamsters, and they looked at the recombinant IgG profile. And what they noticed is that actually zinc supplementation reduced IgG galactosylation. And if you remember, galactosylation is you can think of it as an anti-inflammatory glycan trait. So what basically happened was that it was not simply zinc's fault. It was that by supplementing zinc, the ratio of zinc to a different mineral called manganese was not kept to normal values, and that basically triggered off this enzyme, which puts galactose units onto IgG glycans to not work as efficient as it would normally do. Whether and how this is sort of and how this could potentially be seen as useful in human beings is a good question and to answer that, I guess we just simply need to investigate it thoroughly. The next supplement, which is also very popular, are probiotics. Here is a really nice overview of the effects of probiotics that have been so far looked at in animal studies. And as you can see, they have possibly many positive effects and benefits. So far, we also see that they help with many of the hallmarks of aging, from telomere shortening to mitochondrial dysfunction, as well as inflammation. And actually, in animal studies, lifespan and health span seem to be improved with probiotics use. This is just to show you in a picture of how these probiotics might work and might modulate pathways in the gut. They basically influence many different cell lines. Certainly, one of the ways for them to work is to affect T cell differentiation, basically eventually favoring the production of anti-inflammatory cytokines. They also influence natural killer cells as well as macrophages, where they again favor the anti-inflammatory cytokine release and disrupt the pathway that leads to the release of pro-inflammatory cytokines. So really interesting for somebody who might be an immunologist. In terms of the effects of probiotics in humans, so clinical studies have so far looked at many different diseases. So as you can see, autism and Parkinson's here are mentioned as well. I guess in cases of these two, any new treatment or any additional sort of management tool is always welcome. There was one study that showed that actually in Parkinson's patients, probiotics seem to improve motor symptoms and also help with the gastrointestinal symptoms. And that was also shown in a study that looked at autistic children in whom, yes, so both gastrointestinal symptoms, but also their behavior was helped with the probiotic use. When it comes to sort of gastrointestinal disorders, evidence is mixed, especially in terms of inflammatory bowel disease, where it looks like probiotics might have an effect on remission and so maintenance of remission and prevention of relapse, but that will differ between different studies. In celiacs, it looks like if gluten-free diet is maintained and only on that condition, then probiotics can be useful as a safe and promising adjuvant therapy. What I think will be interesting in the next couple of years and decades is probably has to do with obesity prevention, where there have been some few studies looking at probiotic use there, but also so far results have been conflicting. Another supplement that I have come across when during my work here as a glycinate advisor has been DHEA and its sulfate form DHEAS, which, as you probably know, is a hormone that's hormones that are released from the adrenal glands together with cortisol. The sulfated form is much easily measured in the human blood, and it's much more stable. And you can see, when we are born, and up to the age of, say, in the mid-20s, so 25 to 30, that is when the DHEAS levels peak. After that, we slowly tend to lose them, and by the time we're sort of 60 to 70, we only have around 10 to 15% of the initial levels remaining. DHEAS and DHEA are very important as testosterone and estradiol precursors, especially in postmenopausal women who are not on hormone replacement therapy. One other reason that I'm mentioning this supplement is that this is a controlled substance in virtually every other world in the country, but in the US, where you can buy it over the counter. If you look at the evidence behind its use, effect on health, quality of life, you will see that meta-analysis mainly showed that actually both in women who have, especially postmenopausal women with normal adrenal function, and in men, DHEAS doesn't seem to make any difference when we talk about sexual function, bone health, quality of life, and carbohydrate and lipid metabolism. A third reason why I'm bringing up this supplement is something that became evident during the COVID-19 pandemic. So basically what was observed was that individuals who were taking DHEA and not DHEAS, so only this form, so DHEA, were basically having worse COVID-19 outcomes. So what happens is that DHEA is quite a powerful and uncompetitive inhibitor of G6PD enzyme. And as you know, this enzyme is crucial in the different cell metabolism pathways. And loss of this G6PD activity basically sensitized human cells to coronavirus infection, making them more prone to basically get infected. This does not happen when individuals supplement with the sulfated form, because the sulfated form is not an effective G6PD inhibitor. And the way the sulfated form goes into the cells is very much regulated. Whereas with DHEA, we can see that this is a lipophilic form, so it basically bypasses what would be normal androgen hormone controls. What's also interesting, and this hasn't been looked into in humans yet, but some dog studies, and dogs were taken because dogs have quite a similar anatomy to us in terms of adrenal glands, is that DHEA supplementation can cause a systemic inflammatory reaction. So obviously, this was something that that we have seen with G6PD being inhibited during the COVID-19 pandemic, but it also leaves a question on the what the overall effect of DHEA supplementation could be on health. So if one is to supplement, they should be using the sulfated form and not the unsulfated form. The last few supplements I wanted to just tell you a bit about are, so the first two are NAC and glutathione. So we mentioned NAC at the very start of the webinar. As I said, it has been used as a management tool in paracetamol overdose. It has been in the last 30 years used as an oral supplement, mainly because of the antioxidant actions. It has, so NAC itself has direct antioxidant action, but what's most important is its ability to basically be a part of glutathione synthesis. So L-cysteine, so amino acid, is one of the building blocks for glutathione. So if you increase NAC, you will get more glutathione as well. NAC is also an anti-inflammatory agent, and also has disulfide breaking activity. If you look at preclinical models, so NAC supplementation has been related to improvement in different hallmarks of aging, and also in sort of memory deficit and decline, in helping slow down the age-related hearing loss, as well as oocyte aging. In humans, however, so far there haven't been that many studies at all, so we still do lack some convincing evidence to support the use of NAC to say that that has any effect on human health span, lifespan, and or mortality. One such study in humans, it has been, well, that was done in 2021 as a pilot study, and then was published as a proper randomized clinical trial in the Journals of Gerontology in 2022, was this study by Kumar and colleagues that actually looked at supplementation of not just NAC, but a combination of NAC and glycine in older adults. What they looked at was many different outcomes, and this is just sort of summarized in this table here. So they looked at the effect of such a powerful combination on different oxidative stress parameters, mitochondrial fluid oxidation, inflammation, insulin resistance, all the way to sort of different functions, so speed, walking tests, whip strength, as well as different cognition tests. And they've seen massive improvements in these 60-plus-year-old older adults who were taking this combination of NAC and glycine. The caveat to this study was that it was fairly small, that the exclusion and inclusion criteria were quite harsh, and that actually these older adults were taking a lot of both the glycine and NAC. So if we're talking about an individual of, say, 80 kilograms, so this was basically based on their weight, such an individual would be taking 8 grams of both the glycine and 8 grams of NAC, which are quite big quantities. So as I said, this is just to kind of show you how this glutathione is built, and the reason why glycine was used together with NAC. So glycine as a building block, is needed for glutathione. We also need glutamate, and from NAC we get the cysteine. And that combination was deemed more powerful than just giving NAC itself. When I read this, well, I kind of asked myself a question, okay, why would we not give just simple regular glutathione? Glutathione is not that stable, and the bioavailability would be really low. So that's why we need to go for something like NAC in the first place. Why would we even want to supplement why would we even want to have more glutathione? So by the time you reach around 4 to 5 years of age, what happens is that glutathione's capacity to deal with the amount of oxidative events in the body is basically reached its maximum. So our body can deal with it up to a certain age, and after that, that process doesn't seem to work all that well. And the last supplement I wanted to tell you a bit about is an NAD and its precursors. So as you know, NAD is an important coenzyme, and it exists in NAD plus form or NADH. It has quite a few precursors, so NMN, NAM, and NR, and we are able to synthesize it from sort of the very start using the amino acid tryptophan, but majority of our NAD basically gets recycled and reused from the mentioned precursors. In terms of animal studies, so in vitro and in vivo studies have actually shown that now NAD supplementation can help prevent and reverse hallmarks of aging, which was something really exciting. Lifespan-wise, animal studies didn't really have uniform results. But more recently, you'll find that there are many human clinical trials registered that actually are looking at NR and NMN being the top two precursors for NAD. Most of the NR studies so far looked at its bioavailability, whilst NMN actually looked at some clinical outcomes in older adults. There was one study that in the elderly showed that 12 weeks of NMN supplementation helped reduce drowsiness and also help with mobility and leg function. There was also this RCT that in postmenopausal women found that actually NMN might even help with improved insulin sensitivity. So there are these studies here and there, but not much so far that has been done. Again, why not NAD? Because of its low bioavailability. So NMN and NR seem to be much more able to get into the cell and do what they should do. So that's why these two precursors have been looked at. Which precursor is better, NMN or NR, in terms of bioavailability and other parameters hasn't been really explored yet. So in terms of human studies, so we definitely need more studies ongoing and to see what the effect on health span, lifespan, and hallmarks of aging would be. I just want to bring something else to your attention. So I wanted to also say that, as you know, NAD levels decrease with age. So what happens is that what we observe in the cells that basically stop dividing, so senescent cells, is that the senescent cells have quite a pro-inflammatory environment around them, which helps mop up all the NAD there is. Plus, they also release an NADase that breaks that NAD down. And in a way, that seems to be by design, because otherwise, if there was a lot of NAD around these senescent cells, they would be more likely to divide again, and that would, make it much more likely for tumors and cancers to form. And this is something that was looked into in rats. Basically in rats who predisposed, so who were genetically modified to be predisposed to developing cancer, and these rats were giving NAD supplements, which basically just help the malignancies form. So one thing is, what we have to bear in mind is that we either have to, if we are supplementing NAD in human beings, we have to observe and be aware of both the anti-aging, but also the effect that NAD might have on tumor formation. So in that way, we either have to deal with the senescent cells first and then supplement, but also think about, in terms of personalized supplementation, that not everybody might be a good candidate, especially in those in whom there is a personal or family history of some form of a cancer. And this on the right hand side is just to show you that apart from NMN and then NR, niacin is also another source of NAD+. We mentioned niacin a few times. It seemed to help with systemic NAD deficiency in adult onset mitochondrial myopathy. So definitely another source of NAD that will need to be looked at in the future. So bottom line of all this, so we mentioned some few RCTs, meta-analysis, systematic reviews, observational studies, and what you will find if you look at the evidence behind supplement use, that in a majority of, what majority of observational studies find, and their findings may not match what RCTs find in the end. And this, one of the reasons this happens is that RCTs, as I had mentioned before, they do not often capture the baseline nutrient level. So if you remember that example of zinc supplementation in Australia and say Sri Lanka, if your Australian individuals already have optimal zinc levels, then you will likely see no difference at all in supplementing that zinc further. But if you are deficient in zinc and you supplement it again to an optimal treatment level, then you might see some effect on different clinical outcomes. So I think what should be definitely done looking for, going forward, and in terms of study design, is looking at different subpopulations, obviously making a difference, and knowing your population in terms of deficiencies, but also looking at different individuals who might have different dietary preferences, and there's so many these days, and also exploring the synergistic interactions between different nutrients that we had seen sometimes can make some combinations that do not favor certain outcomes. And the last thing is really moving away from just recommending everything to everyone, but actually advising that personalized recommendation approach. And I think that is best seen here. So this is taken from a really good paper that was published in Nature just maybe 10 days ago. So I would definitely recommend you have a look at it. It's basically a look at the evidence-based medicine today and where it might head in the future. So in terms of supplements, what we have now is just the tip of the iceberg. We have, so we have different levels of studies, meta-analysis, systematic reviews, and I do agree with that if we want to make something personalized, we need to find ways to better utilize that data, and there are, so many different technologies available these days for us to use them in the best way possible. And so I think it is about that kind of conscious choice of saying of using the shallow evidence just for any patient to recommend anything, or actually use and find out and dig out some deep evidence for each individual patient. And this is it. So this is everything that I wanted to tell you about. Thank you for listening. I'm happy to take any questions, and happy for, any comments you might have or anything you wanted to discuss. Yeah, so I think I just want to respond to, yes, so to Anthony Lawrence's comments, absolutely. So quality is quality of supplements, and I think you mentioned probiotics, obviously different strains of probiotics as well. But yes, quality of supplements, one of, I would say, agree with you, big issues at the moment. So we have a question from Yulia. Have you looked at the longevity effect of compounds from plants like cannabinol and curcumin? So I haven't had a look at those ones. So I think in terms of herbal medicines and different botanicals, so many different ones to look into. Curcumin is one of the ones that is commonly used as well, and anecdotally, people do report really positive findings in terms of subjective feeling of inflammation being reduced. But I'm not aware of any studies or any objective parameters that looked at this supplement specifically.